The title of my presentation today is the 340B Program Reconsidered, Taxpayer Dollars and Corresponding Oversight Requirements. That's what I'm going to talk about most today. And really what that's going to be about is posing some questions that I want stakeholders, all the stakeholders in the 340B program to start thinking about, because it's the right time to do so. Why is it the right time to do so? Because as Commander Pedley mentioned, we're going to have our first comprehensive rule in the 340B program come out no later than June. Now is the time to think about what that rule should include. And so what I will be talking about the Medicaid drug rebate program a little bit at the end, because it just wouldn't feel like IIR if I didn't do that. And I'm going to talk about the President's budget from last spring and what some choice provisions in that budget mean, not just for the program, but give us some hints about what we might see in the final rule when it comes out. But what I want to start by talking about is asking the question and encouraging everyone in the room to ask the question about whether 340B discount dollars, those discounts that manufacturers provide under the 340B program, whether they should be viewed as taxpayer dollars. And the reason that's a question is because if they're viewed as taxpayer dollars, like any other taxpayer dollars, to me it suggests a level of oversight that has to go with them, and that level of oversight is absolutely not in the 340B program today. So I'm going to go through some reasons why it makes sense to at least ask the question about whether 340B discount dollars should be viewed as taxpayer dollars, and then I'm going to talk a little bit about some of the oversight provisions that you see in other federal programs where this kind of money is involved, or at least analogous programs, and some of the oversight provisions you see in those programs, and why it makes sense to include those sorts of oversight provisions here. I'm also going to talk a little bit about what you need to be doing about the 340B program in your own business to make sure that you are doing what you need to do to monitor the impact of this program on your business every day. Last but certainly not least, there is a disclaimer at the bottom of this slide. I'm really here to ask questions. My questions are my questions. They're not necessarily the positions of my firm or of my firm's clients. And it's not really a policy position, but it is something that I want people to start thinking about because now's the time to do it. So let's start with, what is the 340B program about? Is it about discounts or is it about program savings? Isn't it just a discount program? This is actually one of the key fundamental policy debates going on around this program between industry stakeholders. If you talk to AIR 340B, I look at that and it sounds like Air Jordan, but it's AIR 340B. It stands for the Alliance for Integrity and Reform in 340B. It's a multi-industry stakeholder group. If you look at their website, they say the purpose of the 340 law is to support access to prescription drugs for uninsured indigent patients. They really think this is about just giving discounted products so that covered entities can have those discounted products for patients who are under or uninsured. SNAPA says no. 340B is not and never was intended to be a simple pass-through benefit to patients. It's not just about discount, it's something more. And these slides, which you'll be able to get after the program, have sites to where I got these statements from. So if it's more than a discount program, what else is it about? SNAPA says program savings. What are program savings? It's the money that covered entities make when they're able to use 340B product on insured patients and get full commercial reimbursement rates. As SNAPA says, Congress intended for covered entities to use the benefit of the discount. The benefit of the discount. I think that means revenue. The benefit of the discount to reach more eligible patients and provide more comprehensive services. HRSA, I think, appears to agree. They say on their website, the 340B program enables covered entities to stretch scarce federal resources. How do they do that? Because they get extra money from the program. So they can magnify the federal money they get with the extra money that they get under the 340B program, stretch those resources, isn't that a great metaphor for money, and reach more eligible patients and provide more comprehensive services. So one other thing to keep in mind as we go through these questions is what I'm talking about today is not challenging the scope of the program, whether it's right or wrong for covered entities to be able to use 340B products for insured patients and pocket the difference. What I'm talking about today is if that is how the program is going to be run, then we have to face what that means in reality. And what it means in reality is that it's a moneymaker for covered entities, and that's why you've seen the expansion of the program. So if it's a moneymaker, what is it? It's the program savings euphemism. If you read the SNAPA website, if you read 340bfacts.org, which is run by SNAPA, they use this term program savings. They never explicitly define what it is, but it's really program profit. It's just, I mean, you can call it one thing or another. You can understand why they'd rather call it program savings rather than program profit, but that's really what it is. I mean, it's certainly savings, I grant them, to the extent it's about being able to use lower cost product if you have to give it to someone for free, because that's some savings. But part of program savings absolutely also is the revenue that they make when they can give it to an insured patient. SNAPA says the program's intent, its lawful purpose, is to allow covered entities to lower their drug costs without lowering their revenues. That to me means you're making money on the program. So where does that money come from? Well, obviously it comes from manufacturers, and frankly it also comes from commercial insurers when they are paying full freight on a product that the covered entities got at a discounted rate. And SNAPA makes it very clear. If 340B were restricted, manufacturers would get to keep more money. So this is clearly about a revenue shift. We need the discounted product because we want to have that money instead of manufacturers because we're going to put it to good use. And that's what the program is about. So if that is what the program is about, and if that is how is it administered, then let's be clear. It is a revenue shift, pure and simple, from manufacturer to covered entities. All right, so it's a revenue shift. Now let's talk about what that means. Well, if you talked again to SNAPA, they say, and I don't mean to pick on SNAPA, it's really, they have the best organized mission statement, most clear mission statement and materials on the web, but there are other stakeholder groups out there. But they say 340B saves taxpayers money. The program savings is saving money for federal, state, and local governments and taxpayers. It reduces government expenditures and reduces the burden on taxpayers. That is their position. Now, I will say, I'm not sure how much objective validation of that claim there has ever been. If you actually look at the sites that they point to, or the studies that they point to, they by and large come from self-reporting surveys from covered entities, where covered entities are making the representation that this is how their money is used. I don't know if there has ever been a third-party independent audit that this is in fact how the monies are used and that they do in fact save federal money. So they say that they're saving taxpayer money, but which taxpayer? And I sound a little bit like Mitt Romney when I say this, and you know what happened to him. Aren't manufacturers taxpayers too? I think the answer is yes, they are taxpayers. And so basically what the program does is it forces one taxpayer category to fund activities so other taxpayers don't have to, at least if you believe that these dollars actually do save taxpayers money, okay? Then you're clearly saying to one manufacturer, as a condition of Medicaid and Medicaid coverage, we are going to force you to fund one segment of particular activity so that other federal taxpayers don't have to. Why manufacturers? Well, it's clearly a Robin Hood kind of thing. SNAPA says, well, they're already making billions in profits, so we shouldn't care. We shouldn't care if we take some of their profits away because they already make enough. How much? And this number is actually consistent with what Commander Pedley said in her prior presentation. The stakeholder white paper. So the stakeholder white paper is available on the AIR 340B website. Again, it's a multi-industry stakeholder white paper that basically is critical of the scope of the 340B program and how it's run. They say $2 billion annually in 340B discounts on brand drugs alone. $2 billion, and that's from 2008 data, and we all know what's happened to the program since then in terms of expansion, so that number's bigger now. And that number actually is completely consistent with the $6 to $7 million in 340B sales that Commander Pedley, she referenced $6 million, or $6 billion, I should say. The SNAPA website refers to $6 to $7 billion in total sales. If you think about the typical discount rate on 340B products, which is 20, 25, even higher percent, $2 billion in discounts on $6 billion in total sales makes total sense. So we have a program where it is at least in part, if not primarily, for covered entities, about generating money through a revenue shift from manufacturers to use to further government ends, because if they didn't, the federal government would otherwise have to pay for it. And it's not hard to connect these dots. It's just that in my experience, no one has ever connected the dots before. So if you're going to protect the taxpayer, why aren't you protecting all of them, including the manufacturer? What if HRSA spent $2 billion a year, not through a manufacturer to covered entity transfer, but what if HRSA spent that money? What kind of oversight would you expect? And why is that oversight any different if it goes from a manufacturer to a covered entity instead of HRSA to the covered entity? And that's the question I think we need to ask. Because if there is a reason for differential levels of oversight, then we need to talk about why that's appropriate. But so far in this program, no one has. We have a program where there's a direct revenue shift from one taxpayer to another based solely on a representation of compliance. They have to determine their eligibility, but once they're in the program, they have to promise to comply. And there is very little, if any, objective oversight absent the audits, which we know are limited. There's absolutely or extremely limited oversight or accountability of how they actually use the $2 billion in discounts that they get. There's no ability for the manufacturer to question or limit that revenue transfer, and manufacturer's only remedy is limited, ineffective, after the fact. The September audit results, which Commander Pedley referenced, over half of those audited have failed or have a failure, some multiple, right? Look at the list, it's on the website. Over half of the 42 covered entities with finalized audit results have a problem. So we have a program, or actually let me ask you this, is there any other taxpayer-funded program out there with this amount of money, with lack of real-time and objective third-party oversight, with this level of a failure rate? And I would suggest there isn't. Now, what I do want to point out is that we at least have some oversight now, and it's only because of what Commander Pedley and her group have brought. So they have done quite a bit with absolutely no resources. So it's not a question of that we are better from where we were, but we are absolutely nowhere near where we need to be if you actually agree that these should be viewed and treated like taxpayer funds. So here are the questions that I think stakeholders need to ask, and they need to be able to answer as we move forward with a rule and as we decide on the level of oversight that we do or don't have. Why should the standard of oversight of federal taxpayer dollars be any different if the money is a direct taxpayer-to-taxpayer transfer mandated by federal statute rather than an expenditure by the federal government itself? Or put another way, should 340B discounts be viewed as taxpayer dollars? And if not, why not? So what we did in preparing for this, or really what I did, is I actually just did a short survey of what are some of the oversight provisions we see in other federal programs, and how would they align with the kind of program we have here. So just to get people thinking about it, this is not a complete list, it's really, frankly, just the tip of the iceberg, and hopefully as people ask these questions and think about other types of controls, we'll come up with even more options. Representations of compliance. Does open access to revenue require more than a promise to comply? Because let's be clear, when someone signs up for the 340B program, after they do go through the rigorous vetting process that HRSA has in place, but once they are in, do they have to do anything before they turn on the spigot of money that is the 340B program? And I think the answer is no. They have to promise to comply. There's no requirement that they submit anything. There's no independent controls or verifications before they do that. Covered entity recertification certainly is a right move. They actually have to promise to comply. They have to promise to report noncompliance. But once they're in, it's unlimited access. A133 audits are also a really good start. These are the audits that certain federal grantees have to undergo, but it's not clear to me that this audit requirement applies to all covered entities. And even if it did, it's incredibly limited. If you look at what actually happens in an A133 audit when they look at the patient definition, you know what they do? They ask the covered entity, did you determine this person was a patient? And if they say yes, they pass. There's absolutely no looking behind that determination, whether it was a legitimate determination. The actual standard is determine that the covered entity determined that this person was a patient, but no questioning of whether that standard was applied appropriately. So the question I ask is, what about accreditation? We see that in other programs. The first example is durable medical equipment suppliers. If you want to sign up and be a DME supplier under Medicare, you have to be accredited by a CMS-designated and approved independent accreditation organization. They have to get this before they can start accessing federal money. Now, the peer-to-peer program that Commander Pedley talked about was actually interesting in that regard because it looks like it is almost the start of that, but it's really mentoring. It's not accreditation. It's not a requirement. If DME suppliers have to do this before they access federal revenue, why don't covered entities? Another interesting example comes more from the corporate commercial context than from a federal program, and it's the SSAE 16 attestation. that systems of controls are in place. This is an accounting standard that's issued by the AICPA, the accounting group, and it was replaced the standard that you may know as SAS 70, but it's basically a situation where an accounting firm goes in to an entity to confirm that they have a system of controls in place. It's for service organizations, which is what these covered entities are. Do you have a system of controls in place for whatever it is that you need to control? And it requires management to attest that they've put it in place and that they think it's adequate. It requires the accounting firm to actually validate that those controls are adequate. And my favorite part about this is that it can also include review of sub-service organizations, which I think would include contract pharmacies. So HRSA could require that covered entities, before they enroll in the program, have this certification or this attestation, and that attestation demonstrates that they have a system of controls in place validated by a third party, not only to the covered entity itself, but also to their contract pharmacies. Next question. Should covered entities have any accountability for how they use $2 billion in manufacturer-funded revenue a year? Now, covered entities are passionate in their belief that they absolutely use this money the right way, that they absolutely use this money to serve those who are most in need, to stretch scarce federal resources and the like. But again, these claims are generally supported by self-reports, by surveys by covered entities. There's really no third-party independent validation to that. And this is my favorite quote of all the ones that I found on the SNAPA website. One of the strengths of the 340B program is the discretion it affords safety net providers in tailoring the use of program savings to address the unique needs of their communities. Why is this my favorite? Because it's really code for there is no oversight, and we like that because we can use this money however we want. Tell me any other federal program where that amount of money is involved and you can use the money however you want. So what about applying federal grant program income standards to all program savings? What is program income? That's a term of art in the federal grant community, and so this may apply to at least some of the covered entities already who may have to comply with this under their federal grants that allow them to become covered entities. But what the basic idea here is if you are able to make money because of your participation in a federal grant program, you have got to account for every dollar of that money and demonstrate how you use that money to plow it back in and save the federal government money. So it's basically a very good way of making sure that covered entities are honest. First and foremost, show us how much you made. Don't just tell us how much you saved, show us how much you made. And then actually account and demonstrate, not on the honor system, but with some independent validation about how you use those monies to stretch those federal resources. The other thing I like about this standard is that it can apply to the contract pharmacies that work for the covered entities themselves. Because if the contract pharmacies are making money because of the covered entities' participation in the program, they could be pulled within that standard. That's exactly the point that Senator Grassley made in his oversight letter to Walgreens. I don't know if you saw this in the trade press, but basically it came to Senator Grassley's attention that Walgreens had made or folks who were employed at Walgreens, maybe not employed at Walgreens anymore, had made statements to the effect of how much money Walgreens was going to make off the 340B program. And Senator Grassley said, excuse me, since when was this program about retail pharmacies making money off of manufacturers? And that's what this really goes to. How much money are you making, who's making it, and where's it going? And if that's how the federal government views its own money, when it sponsors a grant at someone, at a grantee, and that grant allows that covered entity to make money, why shouldn't the same standard apply to manufacturer funds? Next topic. What guarantee is there that any refunds will even be available? Remember that OPA directs manufacturers that they cannot deny covered entity requests for discounts under any circumstances. So even if you have reasonable cause for noncompliance, and OPA's agreed that you have reasonable cause because they've agreed to your audit, you still have to keep the spigot open. Even where the audit's ongoing and you're finding bad stuff, you have to keep the spigot open. And it's not until OPA actually goes through their process and frankly cuts them off that you get your money back. And guess what? A lot of these covered entities are safety net providers by definition, which means they probably don't have a lot of money in the bank. And so you are required as a manufacturer to put your money at risk with no ability to stop it, and frankly, with a diminishing likelihood of ever seeing that money come back if misconduct's found. Now, that risk of being able to recover obviously is going to apply to some categories of covered entities more than others, because the bigger institutional providers obviously you're going to be less worried about it. But frankly, I think some of the higher risk behavior is not at the big institutional providers, it's at the smaller providers who aren't going to have the money to repay you. And this is exactly what happened with DME suppliers. That's why we have accreditation standards. That's why we have surety bond standards, which is the next example I'm going to talk about. You had people setting up shop, signing up to bill Medicare as DME suppliers, fly by night, defrauded the government, and no one ever got their money back. And the government got tired of it. So they said, we're going to make sure you're legit before you sign up, and we're going to make sure that you have a surety bond so that we can get our money back if you end up not being legitimate. I'm not suggesting here that covered entities are engaged in rampant fraud by any stretch. But my point is, if you're not entitled to the money, we should be able to get it back if we have no choice but to give it to you when we're worried about whether you're being compliant. So there's the surety bond standard, which is an example. The other suggestion, and this springs forth from the mind of Alice. I can't say that this comes from anything in any federal program, but what about some sort of an administrative injunction process? Why can't manufacturers have a process where they go to OPA and say, we think there's a problem. We want to be able to cut off the spigot because we're not sure we're ever going to see this money again. We will escrow these discounts while we are investigating them. They will get them back in full, but at least we know we have the money, and we'll actually get the money back. And they'll get the money if we're wrong. The other reason I like this idea is it completely incentivizes covered entities to cooperate with audits, because the anecdotal information I've gathered from those who've looked at audits is that covered entities clearly have no reason to cooperate other than hopefully their good faith. But, you know, they have unlimited access to discounts. You can't cut them off. You're asking them questions. What is their incentive to fast track that response? They have every incentive to slow roll it. In my sense, some of them are. But you know what? If you've cut off this discount, they have every reason to start complying and wanting to resolve it, because they're going to want to get back into the 340B program and access those discounts. And so I think at some point in time, there has to be an ability to shift that presumption of availability of funds as long as the manufacturers can demonstrate that those discount dollars are available once the findings are completed. Next. There we go. So we talked about refunds, but wouldn't it be nice if we didn't have to worry about refunds to begin with, and talk about deterrence? Deterrence is the key tool the government uses to protect government taxpayer dollars. Refunds are nice, but prevention is definitely better. I think all would agree on that. Covered entities currently enjoy, frankly, laughable penalties and disincentives. Their civil monetary penalty is interest. In this economy, it's interest, okay? That's nothing. Any person with a reasonable business sense would say, I'll take that risk for that CMP if it means I can continue to get those dollars. They also face the potential exclusion from the program. We have never seen that happen. What we have seen is entities who are already ineligible kicked out of the program. We have not yet seen anyone kicked out of the program who is actively participating due to misconduct. So let's talk about penalties that are applicable to other entities that get federal taxpayer dollars. First and foremost, the Federal False Claims Act. That has become quite an enforcement tool, as manufacturers know. It certainly has incentivized compliance in the manufacturer industry around price reporting. Here's what's really interesting. It's really interesting what you find if you go back and read all those Federal Register notices in the 340B program. The 1996 audit guidelines actually suggest that the False Claims Act might be applicable to covered entity misconduct. So that's an interesting issue worth mining. So maybe we already have a legal basis for concluding it does apply, and it should be applied to covered entities that engage in misconduct. There's also the death penalty for being excluded from federal health care programs. We know that manufacturers face that for misconduct under the Medicaid and Medicaid program. Why aren't 340B entities encountering that for misconduct under the 340B program? And it would make sense if you actually view 340B discount dollars as federal health care program dollars, because one participant is giving the other participant money. If you're engaged in fraud around those dollars, why isn't one potential penalty? In extreme cases, exclusion from the program. And if not exclusion from the program itself, why can't we at least have an exclusion list for the 340B program, which is not just about covered entities, but about consultants or particular employees who are engaged in particularly egregious misconduct. Note for the record that manufacturers, we already face these penalties, right? We're already subject to the False Claims Act for price reporting under the programs that support the pricing data for this, for 340B. We also obviously face PPA termination, although I will note PPA termination hasn't been applied to manufacturers either, so I guess HRSA has been equal in their unwillingness to impose that on any of the stakeholders in the program. So those are some thoughts, right? I just think that, at least in my conversations with stakeholders and in my dealings with the program, I have not seen, the thought that comes to mind is, it's really easy to spend someone else's money, right? And if you're spending the federal government's money, the cost of that is you have to have a system of controls in place, you have to have some oversight. And the question is, it's really easy to spend manufacturer money, especially when you can demonize them as big profit-making machines that don't care about people. But aside from the rhetoric around it, let's drill down into the analytics and ask whether that really is appropriate. And if you want to take that position, and I'm sure there will be some that do, let's have a reasoned discourse around why it is appropriate to treat manufacturer taxpayer discount dollars differently so that we can be open and transparent and have a debate about it rather than what we've had to date, which is sort of a presumption that these are just dollars that we don't have to care about and that the level of oversight doesn't have to be commensurate. And why does this matter? Because we are about to go through a rulemaking process, and now is the time to start thinking about it, start advocating for all stakeholders, because there will definitely be differences of opinion on this issue. Let's start talking about it so HRSA can get that feedback and think about it as we go into the rulemaking process. So, as we go into that rulemaking process, one of the things I think we need to say to manufacturers, or I will say to manufacturers, is stop complaining and start looking into your liability. I think manufacturers are very concerned about the 340B program, but you need to put your money where your mouth is, and you need to actually start overseeing your business exposure to the 340B program. Some manufacturers have totally stepped up and take leadership roles there. I think it is now time for all of us to follow that draft and start moving forward. So I have a bunch of questions on this slide, and you need to be able to answer, if you're a manufacturer, yes to each one of these, and if not, you have some work to do. Have you analyzed your 340B book of business and gross to net impact? Do you know what this program is costing your business? If you don't, you need to find that out. Do you and your executive leadership know which aspects of the 340B program matter most to your business? Is it inpatient diversion? Is it the duplicate discount, whether fee-for-service or MCO, orphan drug, patient definition, contract pharmacies? Depending on your product mix, it's going to be some but not necessarily all of those issues. Which ones do you care about? Have you monitored those OPA audit findings that Commander Pedley mentioned, that I've mentioned, that show a bunch of covered entities found to have violated program terms? Have you identified which of those are your customers? Have you started looking at the revenue and the volume that went to those customers so that you can start scoping out the kind of refunds that you may be entitled to? If 340B discount volume is material to your business, have you created an internal monitoring function to analyze covered entity sales patterns, contact covered entities on an informal basis to raise questions or concerns, and where they can't be resolved, elevate those concerns within your company and pursue audits as necessary? You need to be in the position of moving to yes, if you're not already there, on each of these issues, because this program, in my experience in working with manufacturers, has for too long suffered from what I will call benign neglect. People assume, they know it's there, they haven't paid attention to it, they assume it's not worth a whole lot of money, and it's going to bite you in the rear someday. Because you're going to look to the gross to net, and someone's going to come to you, if it's your responsibility, and say, why haven't you looked at this? Or better yet, you're going to look really smart because you're going to take it to your management and you're going to say, I think we need to take a closer look at it. But you need to manage this the same way you're managing any significant commercial customer. Think about, how you have people assigned to manage relationships with particular plans, particular regions. Why aren't you doing that with 340B? That's where you need to be as we get ready for this rule, because that's going to be your opportunity to influence how the program is used. You need to know the issues. It's called the mega rule, in case you haven't figured that out yet, or at least that's what a lot of people are calling it, including me, because it's going to cover a lot about the program. We have this narrow rule on orphan drug. This is going to cover a lot about how the program works. You need to be prepared for when it comes out so that when it does come out, you can tell your management very quickly, this is what it means to us, this is what we need to advocate about. And that means that before it comes out, you need to do your homework now. And if something's really important, you need to think about going in and talking to HRSA about it now. Because in my personal experience, Commander Pedley and her team are incredibly open and welcoming and interested in learning about the program from the manufacturer's perspective. Because they can't help you if they don't know the issue, if they don't know about your product, if they don't know about the dynamics in the market about your product. And I have never had her say no. And so, now everyone's going to call her, she's not going to have time, but, if you have an issue that you care about, you want to get in and see if you can meet with her while they are still drafting, not when it comes out. And so that means you really need to be looking at these issues now. And then once it comes out, make sure you're ready to brief your management and comment, comment, comment. This is called the notice and comment rulemaking process for a reason. They propose it, you get to tell them what you think about it, and then they have to deal with those comments. They have to respond to those comments and explain how, in light of those comments, this is where they ended up. So this is your opportunity. Don't blow it, make the most of it, and start preparing now. Now, onto the Medicaid drug rebate program. So, take a deep breath. This is the language that was in the president's budget in blue italics, okay? And I read this and I felt like they're kind of describing a blind date. You didn't quite know if it was good or bad or what it really meant. And the language I want to focus on is these proposals clarify the definition of brand drugs, remove brand name and authorized generic drug prices, blah, blah, blah. And we're like, what the bleep does that mean, okay? So we did some digging, although we did know it meant a lot of money, okay? $8.8 billion over 10 years. So we did some digging, and this is what we found out it's about. So when they say they're going to clarify the Medicaid definition of brand drugs, what that means is that legend drugs, prescription drugs that become over-the-counter are still considered brand drugs. So just because you go from prescription to OTC doesn't mean you go to non-innovator status. But I think more importantly, because I'm not sure that's a big newsflash, more importantly, they want to remove the term original from the phrase original NDA, which is what the statute uses to define products that are innovators and single-source drugs. To be a single-source drug, you have to be a drug originally marketed under an original NDA. And that term original is a problem for CMS because CMS wants to take the position that if you're approved under any NDA, pre-Hatch-Waxman, paper NDA, doesn't give you any market exclusivity or patent protection, any NDA makes you a single-source or innovator multiple-source drug. That's what they put in the proposed rule. Manufacturers with products in these categories pushed back and said, no, original means patent protection, market exclusivity, some sort of market benefit that justifies giving us a higher rebate rate than everyone else. But if this NDA didn't give us any market benefit, we shouldn't have to pay a higher rebate. And we know that that's how CMS originally, pun intended, interpreted this term. If you go back and look at the 1995 proposed rule that was never finalized, CMS said in 1995, we think original NDA means an NDA that gives market exclusivity and patent protection. Now they're trying to back off that. Manufacturers have said no, the statute says original NDA. That term original has to have meaning. That means you can't go this route. Well, guess what? Now they want to delete the term original. Next topic, exclude brand and authorized generic drug prices from Medicaid federal upper limits. This would basically just leave true generics, what you think of as a true generic product, in the federal upper limit. It's a reminder that the AMP statute is not about rebates so much anymore. It's about federal upper limits and reimbursement rates. And so it would exclude those brands and authorized generics from that calculation. And the reason we think they want to do that goes to the next issue, which is they also want to exclude authorized generics from Medicaid brand name rebate calculations. So it would move, in short, this is going to undo, if it's codified, it's going to undo what the DRA did. So you remember the DRA, for the first time, required manufacturers to include authorized generics in the branded product's best price and include the authorized generic in the branded product AMP where the manufacturer sold to an AMP-eligible entity, which is a wholesaler. Under the DRA, that definition of wholesaler was very narrow. Didn't include secondary manufacturers that are going to sell your authorized generic for the most part. Guess what? With the ACA, we have a new statutory definition of wholesaler that specifically includes other manufacturers. So now manufacturers might be able to include authorized generics in their AMP. Guess what that means? The brand manufacturer AMP is going to go very low, And the way the formula works, it's actually going to reduce manufacturer rebates, not increase them. And the whole point of the DRA authorized generic provisions was to make branded rebates go up. That's why CMS interpreted it the way they did in the DRA final rule. This ACA wholesaler definition creates a real problem for that. And it actually, effectively undoes that. And now manufacturers, under certain circumstances, can include authorized generics in their AMP and they can start saving money. CMS has figured that out. They basically, I think, effectively recognize that in the proposed rule. And they don't want that to happen anymore. And so they're saying, we're going to basically undo. My read of this, based on that really general language and some digging we did, is that they're going to basically undo that and pull authorized generics out of branded products AMP and best price. So the branded product rebate's going to be based on the branded product sales alone. But that's also why I think they don't want authorized generics in the brands and the full anymore, because they don't want the full to be tainted in any way by skewed pricing from authorized generics. Last topic, they want to correct the Medicaid rebate formula for new drug formulations. So my partner Christy Bloomquist talked a little bit about this in the symposium yesterday. Remember that the alternative rebate formula for new formulations requires that the rebate of the new formulation be the greater of its own rebate, or the new formulation's AMP multiplied by the highest additional rebate or inflation penalty for any of the original drugs as a percentage of AMP. And what that does is it compares the total rebate for the new drug to basically just the additional rebate of the old drug. So it's an apples to oranges comparison. This proposal would fix that, fix the alternative rebate formula. So when you're comparing the total rebate for the new formulation, you're going to compare it to the total rebate of any of the original drugs, and that's going to have the effect of making the rebate on the new formulation bigger. So what does that tell us? Whoever came up with these changes is really smart. I read through these explanations and I thought, damn, they really know this program in a scary, smart kind of way. So, they know what they're doing. These changes are going to cost you a lot of money if they get in. $8.8 billion over 10 years. That's a lot of money if your drugs are impacted by any of these particular changes. Michael Steele talked earlier about the sequester and the need to get a budget. You really need to be watching that legislation because these are money savers. Guess what? That's what they're going to want to have in any budget bill that they're going to need to pass as money savers. And you really need to be connecting with your DC office team or whoever monitors legislation for you to see if these things get slipped in to any bill. Because it's not a routine overhaul. It could be a page long of legislation slipped in an omnibus funding bill. You want to know if it's in there so that you can see if it's going to happen. What does it tell us about the ACA final rule? It does give us some hints because it basically suggests that there are problems that the government recognizes that they think they might need to change the statute, which means they might not be able to do it by reg. If you can only do something by statute, it makes it hard to do it by regs because regs have to be conforming with the statute. So that original NDA problem is a problem. That term original is a problem for CMS, and this suggests that they know it and that they might not be able to fix it without a statutory change. That doesn't mean that they might not try to fix it without a statutory change, but I think it's a little bit of a tell that they know that there's an issue with this term in the statute. CMS is focused on federal upper limits and federal upper limit savings. I work primarily with branded companies. They primarily think of the Medicaid drug rebate program as about rebates, not about AMPs and federal upper limits. I'm perpetually reminding them that this AMP rule is not so much about rebates. It is at least as much, if not more, about keeping the pharmacy lobby happy, but at the same time getting federal upper limits implemented so that the federal government can actually start saving the money that they wanted to save under the Affordable Care Act by lowering reimbursement rates under Medicaid. Authorized generics, that wholesaler definition is a problem and has the real potential to lower rebate revenue for branded products. And CMS might not be able to do anything about it without a legislative fix. And what we already knew, that new rebate formula really is a mess, and CMS knows it, and they want to fix it to make it an apples-to-apples comparison. So keep an eye on that legislation in the fall. It's going to be a really busy time, and you really want to know if this stuff is happening. And then my last point is, you cannot pay enough attention to 340B. Make sure you're talking with your business and your policy folks about it. And with that, I think I'm out of time. So thank you. Thank you.